very good evening to our viewers. Thank you for joining us tonight on the evening review. My name is Clayton Iipinge, your host. Tonight on the platform, we host Clayton Iipinge. He is a medical laboratory scientist with the Namibia Institute of Pathology, NIP. And today is World TB Day, and we are going to venture into that topic today, the importance, the awareness, and everything related to TB. Thank you very much, Clayton, for making time.
Yeah, thank you for having me.
Yeah, wonderful. Tell us what your role at NIP entails. If you're a medical laboratory scientist, what does it mean?
Okay. Yes, so you're right. I'm a lab scientist for short. What it means, we test samples in the medical laboratory.
Okay.
So all the biological samples, anything that comes from a human body that needs to be tested, it comes to us, and that's what we do. Me specifically at the moment, I'm more focused on the testing of TB samples.
Okay.
Yeah, so we've been testing TB, we diagnose, we do any other test that is related to TB in Namibia. That's mainly what I do at the moment.
Okay. The samples would typically come from where to reach you at NIP?
For us, the NIP, we have a mandate towards the public patients. So most of our sample come from public hospitals and clinics, but that does not limit us from testing private patients as well. So we test everyone, and our main sample type that we would get for TB, you would mostly, when you go to the hospital, they would ask you to cough. So it would be your sputum or mucus. That's the one that they would send to us. Whenever they ask you, they'll give you a cup, and then you cough in it, and then they will take it, they give it to us. And then us now, we do our manipulations, we have good technologies, and then we would see if there's TB in that sample or not.
Okay.
But yeah, in these days, because TB is not only in the lungs, it can be any other part of the body, they are also allowed to collect any other sample other than sputum. For example, urine, we do get those. We have tissues and your pleural fluids, or the fluids that you get from your lungs, or any other part, and then we test for TB.
Okay.
Yeah.
When these samples are sent to NIP, it means hospitals do not have internal capacity to do this on their own, or is it at an elevated level? Why would the hospital send it to NIP?
No, the hospital, it's not in their mandate to test sample.
Okay.
Yeah, that is a little bit outside of their scope.
Okay.
You need trained professionals where we come in, and these people are usually in the laboratory, in the lab. So yes, the labs, we do have labs at almost all the public hospitals in Namibia, but it still has to be a medical scientist like I am that has to test for that sample. It's not like they don't have capacity, it's usually because it's outside their scope.
Okay.
Yeah, that's where we come in.
Yeah. What is the turnaround time? Because typically someone is sick, they need very urgent interventions. How often do you return the results?
Okay, we have different turnaround time, obviously, based on different tests that we do. Blood has a much faster turnaround time. For TB, we have some technologies that allows us to do our manipulation and get a result for at least within 2 hours. But then we need time. We need to account for the time it takes for the sample to get from the clinicians to the lab. Usually some of these samples, they are from far to reach clinics, for example, or they are in the hospital, but they're still a distance. So what we inform our client is that we give them, for TB specific test, we give them 48 hours. Yeah, so that we can give them a test. Although the actual testing process, usually it's much less than that. And then we are able to get the results in a much shorter period of time. So if the patient it's a very urgent sample, and then the patient needs results immediately within an hour, for example, we always encourage our clinicians to always just call and reach out to the laboratory and be like, look, I've sent this sample. It's very urgent. This patient is critical. Will you be able to do this manipulation immediately? And we'll be able to do so. That's also not to say that we neglect any samples or routine samples that do not have special requests. No, we also attend them on time. We just give ourselves a specified amount of time of 48 hours to make sure that we have enough time to do all our procedures and verify the results so that when you get it, you are absolutely certain that it's correct.
Yeah.
Yeah.
Where does TB come from? I mean, typically, where does it originate from?
Well, TB is one of the very oldest, diseases in the world. It's caused by a bacteria called Mycobacterium tuberculosis, although there is a group of them that causes them. So in the microbiology, in the field of microbiology, where we're coming from, we would say TB is one of the very good bacteria in such a case that TB is able to hide itself in your system, and usually it does not kill until it has to. So that makes it's able to survive in the host for a very long time. That's why it makes it a very good bacteria, and it makes it very difficult to treat. TB has been reported in the times of the Egyptian mummies. They've discovered it then already, and we still are faced with the same challenges of TB, right? But usually, like with the TB, it's because it's a bacteria, usually causes lung infection or a respiratory infection. It's very easily transmissible between the two people, like me and you now. We are in very close proximity. So
I hope you're immune.
Yeah, I hope so too.
You deal with these things all the time. So.
Yes,
Yeah.
I hope so too. So when two people are in close proximity or in an environment where there's very poor ventilation and the infected person coughs, this TB is usually now in the droplets, in the saliva. Yeah, so it can also survive on surfaces, although not for too long. So you can easily get it and then carry it, and then you can get an infection.
Okay.
Yeah, that's how it normally spread from person to person. It's infectious and it's spread through the air or droplets in the air. Yeah.
Is it a disease that is influenced by socioeconomic conditions? For example, I know, for example, that what was the disease that was the one that comes from contaminated water?
Cholera. One of them is cholera. Any of the diarrhea conditions.
Yeah, I can't remember the name now.
Oh, is it HPV? No, sorry, not HPV. Hepatitis E. There was a hepatitis E outbreak.
Yeah, hepatitis. Yes. That one, because that one was prevalent in areas in Windhoek. It was confined to your informal settlements where there's no proper sanitation and stuff like that. So TB, is it similar? Does it come from those kind of conditions, or it can also be prevalent in your leafy suburbs?
Okay. No, you're right. There is a correlation of TB and the socioeconomic status. Yeah, it has been like the other diseases, mostly confined in the people with poor hygiene, low living standards, whereby there is no proper ventilation, and overcrowding. Overcrowding is a problem, which is usually a problem of people of low socioeconomic status. Yeah. Right. So so it can easily be spread there, and also hygiene and food or nutritious food intake. Right. People who are likely, people who have less are likely to have poor poor food or dietary requirements that is required. Likely to live in an environment that is not properly ventilated and overcrowded, and then they are likely also not to access medical care and stuff. So it does influence the spread of TB in that community, compared to people that are much better off, that are able to segregate themselves in their dwelling, in their houses, because there's enough space. And also the statistics, if you look at the WHO statistics, we see that the high burden for TB is mostly in low-income countries like Namibia, while the European countries and the much more well-off, they seemingly doing well. They are able to curb it and then the spread, and then to treat it much better. So socioeconomic status does influence the TB spread.
Absolutely. How prevalent is it in Namibia in general?
Okay, so if I say numbers, might not make sense, right? Because but what I would want to say is that TB in Namibia, in particular, have been classified by the WHO, or it's ranked as number 11 in the whole world, not in Africa. Not in Africa, in the whole world, we are classified 11 with one of the countries with the highest TB burdens. Wow, we used to be worse off than that. We used to be, I think the lowest was, more recently we're at 8. I think previously in the early in 2010s, we were like around 5.
Okay.
That means, yes, TB prevalence in Namibia is very high. So usually what the WHO does, that the top 10 countries are considered obviously high burden country. Since now we just moved up a space above, we are now at 11th position. We are still high burden, although not danger, but we are still on the watch list. So yeah, but it means that Namibian prevalence is still high. But also to make it worse is that we still estimate that there are about 38 potential TB cases that we are missing in Namibia, right? So if we're able to diagnose and identify all the potential cases that we have, I'm sure our burden would be much higher, than what we currently are. But as it stands, we're not doing so well. Our burden is really high.
Yeah, those that you said, you said something about those that have not been detected.
Missed, yeah.
Like, how does that come about?
Okay, so of course they are missed in a sense that, okay, the WHO, for example, and also our Ministry of Health, they have tools, right? So that sort of estimate how much cases we are getting. But at the end of the day, when you do your analysis, you only say, like, you have only diagnosed this many people, but there should have been more. Yeah, then that also now leads you to, like, what is happening. So then we came to a realization that there are a lot of cases that we do not diagnose or test. Most of the time it's because the patient have been misdiagnosed, right? Sometimes because TB manifestation is similar to many other respiratory infection. You are coughing, sometimes you have weight loss and stuff like that. This can be also be associated with many other respiratory diseases, such as bronchitis and stuff. Other patients, especially in immunocompromised, may not even present with these symptoms, and also HIV infected people. So it leads to them not being tested, or it does not alert anyone or a clinician, does not prompt them to collect the sample to test for TB. Another case that have been missed mostly, it's for example, it's lymphoma. Lymphoma is a type of cancer that affects usually children, and they would have like swollen lymph nodes, usually in the lung, in the neck, and so forth. Sometimes TB also has similar manifestation, but usually when these people present to the clinic, the first assumption it could be a lymphoma, for example, and we never really get to test for TB, so we miss them. And of course, the other obvious one is the access to healthcare. Yes, although the Ministry of Health has really tried to do a good job to make sure that everyone is at least accessible, or they have a health clinic within a 30-meter radius. There's still a lot of people that do not actually access the healthcare, and sometimes the resources are not there. Could be as simple as a collection tube where they're supposed to spit. Sometimes it's not available. Yeah, so that they do not now get a sample tested, and we do not get to diagnose them. So those cases we are missing. What the ministry has been doing, and sometimes NIP helps, is that they do periodic screening, whereby they go out in the community and then they just try to screen everyone. Doesn't matter whether you have symptoms or not, because usually it's the asymptomatic people that we are missing. And then they try to draw a sample, and then it sort of assists in picking up some of these cases, but it's still not all of them.
Absolutely. We go for a very short break and then return with Clayton Iipinge. We continue on the evening review, the conversation around TB with Clayton Iipinge. The NIP, how is NIP aligning to the theme of the day? What is happening there?
Okay. Yeah. So yes, today is the World TB Day.
Yeah.
Right. Yeah. So the Ministry of Health this year decided to celebrate the World TB Day under the theme, yes, we can stop TB. We must commit, invest, and deliver. Okay, so how do we now align as an NIP organization? In terms of commitment, NIP actually runs a network of laboratories throughout the country. We have about 38 laboratories throughout the country, stationed at most state hospital, and 32 of them, they do TB testing. Diagnosing. Yeah, that's a really big commitment. There's also, it's really good. It also brings the service close to the people. So it also prevents the sample from being sent, for example, all the way to Windhoek. Then you have a longer turnaround time. It can be tested right there. So we're committed in that way. In terms of investment, yes, the TB testing requires very sophisticated machineries. So we have committed or invested in these machineries and also invested in competent staff, right? So you need people that are competent or trained, can even be specialized in this field. So we invested in that, heavily invested in that case. And also like we invested in also in a way that the World Health Organization continuously try to align the diagnostic to make sure that we can accommodate everyone, or we can diagnose the TB correctly and make sure that the drug sensitivity, for example, it's accommodated. So this year, and I think the ministry is also busy launching this right now, there's a new diagnostic algorithm. They have made changes to the way that we should be testing for TB. With these changes means that we need now new technologies. So we are now in the process of acquiring these new technologies and make sure that we train staff that will be able to assist, so that we make sure that we meet the needs of the nation and of the ministry. And also delivery. We're okay, because part of the theme, I would say that we deliver in terms of that our turnaround time, we try to shorten it as much as possible to make sure we keep to 48 hours, but we also find ourselves that most of the time we do not wait for 48 hours. We try to give the results as soon as possible. We try to communicate to the clinicians, especially if there's a term what we call resistant TB. This is the TB that does not respond to most drugs, right? So what we made sure is that whenever you came across this case, there are as many, you made sure that you immediately notify the clinicians, because this patient needs to be isolated, needs to be implemented on the treatment as soon as possible. So we sort of commit in that way as an organization.
Okay. And in terms of the technology that you guys have, how sophisticated are they? I mean, I'm asking because, to avoid things like misdiagnosis and also just to make sure that the turnaround time is not too long. How sophisticated are your equipment?
Very sophisticated. Yeah, this is why you also now need highly competent people to operate them. But they are sophisticated in terms of how they operate and to make sure that they do not miss. Most of our instruments, mostly the gene expert procedure, it's a molecular biology. So it tests for the DNA. For the DNA of TB. So yes, we are doing DNA testing for TB already. But they are also sophisticated in such a sense that they also it's packaged in a way that it is also a little bit robust to contamination. That you cannot just when you are sneezing and then you can contaminate the sample easily. It's sort of like try to eliminate that to make sure that you don't give out false results. But we also have more complicated technologies but although these ones are centralized here at the in Windhoek, although they are still accessible to everyone countrywide, they just need to send the specimen here to Windhoek. Here we do now TB culture, which are even more sensitive, although they are very prone to contamination. So we have to have a laboratory, we call it a biosafety level 3. This is one high containment lab, whereby you have to suit up and then wear proper gears and stuff like that so that you manipulate this sample. But it's very sensitive. It's very sensitive procedures that it can pick up very minute bacilli. So we try not to miss out on anything. At the moment, it's only available in Windhoek, and it doesn't really make sense to decentralize it to other labs, because they are doing not like point of care, but they have enough sufficient technologies or instruments at the sites where they can diagnose the TB immediately, and the rest they can send to Windhoek, and then we even do further diagnosis.
Okay. You spoke earlier about TB not being you called it the bacteria, that it doesn't. It can remain in a host for some time without causing any ailment and whatnot.
Yes.
But in general, how dangerous is TB as a disease?
As a disease.
I mean, what are the rates of the chances of survival once you caught it?
Okay, so TB infection, so I'm using the term infection. Infection, there's a difference between infection and disease, right? So TB infection, there are reports that could be up to 80% of adult population, especially of the African origins, have been infected with TB. It's possible that me and you probably have been infected. This does not mean we have the disease. It means that we have been exposed or at some point in our life, we have inhaled this bacilli. But because it's a very good bacilli or bacteria, it's able to stay in our lungs in a capsule that does not evoke or does not an immune response. Your body will not see it or will not see it, so it will just remain there dormant. But if conditions changes, then it will cause a disease. Those are the people that you need. When it's in a dormant state, we call it latent TB. There's very little interventions you can make for this patient, because just as much as your immunity, there's no access to this bacilli, you may also not reach it with the drugs. So you can't sort of like treat it in that state. Yeah, you can treat it, however, if the person now start being sick. Now this is in the disease state. But the good thing about TB, it's very it's treatable, right? So if you are diagnosed on time, we have the ministry has a cocktail of drugs, right, that they would give you. Yeah, and then these drugs, if they are taken correctly, you will be able to make 100% recovery and to complete the course, and you'll be treated. Yeah. But complications do happen though. For example, mostly it's complicated with inadherence. If you give the patient this cocktail of drugs and they don't take them, or they don't take them as they're supposed to, they may develop what we call resistance.
Okay.
Yeah, so this would require now even much more stronger drugs, which can cause now even further complications, like your liver can be damaged. Sometimes there was a drug in the past which it's now been they're limited to use now, but there used to be one of the TB drugs that caused hearing losses. Yes, so yeah, so it's treatable, but there can be unintended consequences, such as developing resistance or getting other conditions, liver disease, sometimes hearing loss. Yeah, but it can be treated. It's treated, and the good thing I should mention is that Namibia in the last year have reported a 90% treatment success rate, which is very good considering our high TB burden. Yeah, and you want to be able to treat the patient completely so that when they go out there, they do not further spread the disease. Yeah.
Is it apart from those conditions that we spoke about earlier about living in congested settings and all those low income conditions that may act as catalysts for infection? Is there anything that one can do to prevent, apart from those? I mean, for example, maybe to make your body resistant a bit, what you eat and whatnot, some lemons, cocktails, to make sure that if I come across a person coughing, it doesn't immediately sneak into my system.
Yes. So if anything we learned from the recent tragedies we had, for example, the COVID-19 pandemic, is that we have learned ways on how we can easily contain respiratory diseases and spread of these diseases. So with that being said, the similar precautions we did for COVID also works for TB. So wearing your mask, especially when you're coughing, right? When you're coughing or you're in contact with someone that is likely to be sick and stuff like that, it's one of the biggest preventative measures that you can do. Of course, the hygiene and good nutrition. For example, your fruits, eating healthier products with vitamin C because they boost your immunity, good hygiene, and also just seeking medical care. There is also another, I know it was a hot topic during COVID, but there is a very successful TB vaccine. It's called the BCG. I think, speaking under correction, but I think the ministry have incorporated this vaccine in your immunization program that they have for children. Yeah, so this TB vaccine also works to prevent sort of like adverse effect of TB. so that when you eventually get infected, then the body does recognize this bacilli and it's able to treat it or to fight it off. Yeah, but yeah, it works.
Absolutely. The last question to you, Mr. Iipinge, is then going forward with us being 11th in the world. That's not a very flattering ranking.
Yeah.
What must happen to really get us far below where we are now in the world rankings? Whether it's in terms of research or what interventions are actually, what recourse is available to us as a country?
Yes. So for now, the biggest concern is those cases that we are potentially missing.
Yeah.
We need to find them, right? Yeah. We need to find them, diagnose them, and treat them.
Yeah.
Yeah. So these one of the easier ways to find them is under the ministry they do a lot of screening campaigns. Right, so when they have these screening campaigns, that if you are in your location, even if you don't feel sick per se yourself, you don't feel like you are symptomatic and stuff like that, please do participate and get screened. Just submit your sample for TB and get tested so that we can potentially find you and get initiated on treatment. Yeah, so the community awareness is very important. From the lab perspective, there have been research and also new testing methods that have been available or that have been in the market, so that to try to, because sometimes what also happens with the patients that we miss out is that sometimes a patient can submit a sample, right? But then although our technologies that we use are very good and very sensitive, there could be very little amount that would be missed. Patients with like, for example, co-infections or HIV positive. So there are now some other tests that we can use that are a little bit more sensitive than the technologies we have, that uses other sample source other than the sputum. Because, for example, in children under the age of 5, that's one of the highly impacted population of TB patients. And it's very difficult for you to collect the sputum sample from these patients, from these children, because sometimes they don't understand that you should cough and spit out. They would mostly swallow. So in this population, we sort of try and diagnose the TB from the stool. Yeah, from a stool sample when they go, because that one is in any case going to be passed down, and we try to collect that one as a new part of the new interventions or innovations, and try to diagnose it from there. For patients with low bacilli, we also try to test it from urine. So we come up with a test procedure that is very sensitive to and to pick up TB in urine, although for now it only works in patients that are immunocompromised, for example, your HIV patients. We are also doing, NIP has a research initiative whereby in our own capacity, we are trying to do sequencing, whereby you sequence and then you sort of like have a profile of them, because TB resistance, it's one of the biggest concerns for Namibia. So we want to see what is causing this resistance, what mutations do this patient have, and as soon as we are able to understand that, it will be much easier to sort of customize your treatment regimen. You'll be like, okay, Namibia has a high resistance of this specific to this drug, so you stock up on that drug that is likely to work, and then the other one that is unlikely to work, you disregard it. We can also like have regimens that are specific to an individual, instead of just giving them the cocktail that might not work. We try to sequence as a research capacity and then give the patient exactly the drugs that would work for them. Those are the new directions we are going now.
Absolutely. I'll add my own as a social scientist.
Yes.
That we must also get our conditions, people's conditions on the ground, in those kabashus and everything. We have to attend to those.
Yes.
And then maybe it can also mitigate. But thank you, Mr. Iipinge, for making time. I really appreciate your time.
Thank you for having me.
Yeah, wonderful. That is it's Clayton Iipinge. He's a lab technician at the Namibia Institute for Pathology, NIP, engaging us today on World TB Day about what can be done. And the numbers are not very flattering, but we hope what he said today can help us move the country forward. Thank you for watching.